I welcome you all in this third pediatric oncology session on retinoblastoma. We have three expert talks in this session, and I would request all the participants to write their questions in the question and answer box, and we will take the questions at the end. Our first speaker in today's session is Dr. Chantada. He has years of experience of working in pediatric hematology oncology in Argentina. He is a member of St. Jude Global Pediatric Medicine Department, and his main areas of research are retinoblastoma, neuroblastoma, lymphoma, and histiocytosis. And his significant contribution is in the area of translational research in retinoblastoma, and where he has worked on developing innovative treatments and the characterization of this tumor in the developing countries. So I would request Dr. Chantada for his talk on global disparities in childhood cancer with focus on retinoblastoma. So over to Dr. Chantada.
Hello, good afternoon to everybody. Thank you very much for the introduction and for the invitation to this meeting. I'd like to thank especially to dogma. And let me share my screen now to start with the presentation about the global disparities in the management of retinoblastoma. This is what you read in the textbooks. My talk will be quite strong in trying to address that retinoblastoma, the real world in retinoblastoma, and what you see in developing countries, in lower income countries and middle income countries, is different from what you read in textbooks. So you always read, well, it is still the most common intraocular malignancy of children. It's probably almost the only one. There are about 300 new cases in the US every year, and perhaps 5 children die per year in the US. That's an excellent disease-free survival rate. It's probably the highest in all pediatric oncology. So we shouldn't be worried if the situation would be similar in developing countries. And in high-income countries, the major cause of death in retinoblastoma are secondary malignancies. So patients may die 30 to 40 years later, usually as a consequence of their biological background, but also influenced by the treatments we have given, and especially with the use of external beam radiation therapy. So most of the treatments in high-income countries are based on reducing the late effects because the survival rate is excellent. However, what happens in a setting? There are about 8,000 new cases per year in retinoblastoma, and more than 6,000 live in developing countries. That is not surprising. We have more children, and so the children population is higher in our countries. There are big differences in survival. We cannot say that we cure 95% or more of these children. We don't even know what happens with secondary malignancies. We have a probably increased incidence. There are many, I won't go over in detail that, but there are many studies that show that there are more cases of retinoblastoma in our setting. And we have late diagnosis, so we see advanced disease. Patients don't present the same as you see in high-income countries. And to make the matter worse, families usually or often don't accept our treatment recommendations, which are based on the experience in high-income countries. So we need to have our own strategy to deal with this disease. How many children are we talking about here? So you see, it is a little bit blurred, I'm sorry. So you see here that this is a paper we published a decade ago, but I think the numbers are probably still the same, painfully. You see here the number of patients in the last column here, in the last row here in the 8,000 patients, probably 3,000 patients would die of retinoblastoma all over the world. And if you go in the last part of the screen at the far right, you see there that an important percentage of these children would die, not only for systemic metastasis and advanced disease at presentation, but also because families refuse the treatment we propose. So these are the major challenges, and my talk will go over this in greater detail. First is late diagnosis, of course, that, as I mentioned, treatment compliance, and the management of extraocular dissemination and advanced intraocular disease, which comprises about all the patients we see in low and middle income countries. So this is a sketch that Carlos Leal from Mexico has prepared for explaining the diagnosis steps that patients do when they go to different hospitals in our setting. So from the first symptom, he is from Mexico, and from the first symptom to the diagnosis, if we are lucky, in the early stages, it takes about 6 months. And it takes about 3 months from the first time the patients went to the hospital or to some medical care and the diagnosis is made. When it should take a couple of weeks, but it's still early, even in early cases, they're still taking 3 months for that. But in the lower part of the sketch, if you see the first symptom and the first sought for help in patients with advanced stages, takes about 6 months. But later, painfully, and that is confirmed also and published by a group in Brazil and many others, when the patient arrives to the hospital, to the first physician, until the diagnosis is made, it may take another 6 months. So that is a shame. And you probably lived that. You probably heard stories that the patient came first to the pediatrician, say it's nothing, came back, say it's nothing, went to ophthalmologist, maybe didn't have time, didn't see the patient went back to their hometown, took more months to come, didn't have money to come back to the hospital again, and then the disease spread and the child will unfortunately die. So I think that many of the actions that we took for addressing late diagnosis were also taken in Latin America. We were quite pioneers in that, especially with the work from Carlos Leal in Mexico, and from Celia Antonelli and Sidney Eppelman in Brazil. And we tried to target the public to shorten that part, this part of the screen, the part when the first symptom came, when the patient goes first for help. But I think we didn't do our best to improve the other part, the part when the patient already is in the system, and for the reasons I mentioned, the diagnosis is still long. So I think that is something we could do better, because the patient is already in the system. We shouldn't fish in a big pond, because the family already knew that the patient had leukocoria, and you have the child there in the system. We as doctors, we should know about that. We cannot ask for the families to realize that leukocoria is a sign of cancer when the child comes to a hospital and the doctors don't know it. We should start first with the doctors. That is what was done in Mexico, that was done in Argentina. We trained the doctor from medical school and to be more active in them, for them to realize that retinoblastoma presents with leukocoria, and it's something that they should be taking seriously. So we learned that late diagnosis is critical, that awareness campaigns can help, but they are not enough. Then socioeconomical issues play a big role, and the medical delay is probably more easily prevented if we take it seriously. And I mentioned that there is a survival gap in children with high-income countries, middle-income countries, and low-income countries. And I also want to update the slides and to see what happened in 2020, when having the data for that. I think the situation in the green part with lower middle income countries is better in many ones. I think we are around 80% probably now, but the situation in low income countries is probably still unknown. So This is a short sketch on how you manage retinoblastoma clinically. So when patients arrive to a hospital or a clinic, or an ophthalmology clinic, you first ask yourself, has this child extraocular disease? And then the next question is eye salvage possible? When the child has extraocular disease, you know that because you do the MRIs, you know it clinically. These patients should be treated by pediatric oncologists with experience in the treatment of retinoblastoma because they need neoadjuvant chemotherapy. You'd have to avoid enucleation, initial enucleation or exenteration in those patients. This chemosensitive tumor, you first have to give chemotherapy. But then the most difficult decision is, because that depends a lot in the context. The question is eye salvage possible in this child? So there is no clear yes or no answer. That will depend on your resources, that will depend on the family decision. So I will go over that later in my talk. And if the eye is not possible to be saved, then enucleation should be done. And then the treatment should be tailored by pathology examination. So what data are useful for you in Pakistan for planning your strategy? You of course need to know how many cases are you going to see and when other patients are coming from. If you have 2 or 3 patients a year, you don't have to open a retinoblastoma service. You have to refer the patients to other centers with more experience, because it is very important that you centralize the management of this patient. Then you need to know how the patients present, if you're seeing more extraocular disease or more intraocular disease, how many of them are bilateral, and the setting description. You need to know if you are, the resources you have, if you have laser, if you have plaques, if you can treat locally the patients, so you have to work with the ophthalmology, with an ophthalmology hospital, and other factors are needed to be accounted there. And the human resources you have to have trained pathologists, you have to have geneticists, you have to have equipment, you have to have safe anesthesia. I mentioned that because in Asia mostly, there are many patients treated in ophthalmology clinics. Usually adult clinics don't have safe pediatric anesthesia for small children, and anesthesia problems occur. To have psychosocial specialists, very important in your setting, have to approach the families to avoid the issue of lack of treatment compliance. So I'm sure you ask yourself this question. I have many patients with extraocular disease, but no access to stem cell transplantation. What should I do? Maybe you ask yourself, I see many patients with advanced intraocular disease, but I don't have intraarterial chemotherapy. What should I do? You read all the time the benefits of intraarterial chemotherapy. Then when our team recommends enucleation, the family usually refuses it. Should I give chemotherapy first in these patients to buy time and help the family come up with a decision? Does it work in your setting? Some patients could access to a higher complexity of treatment. We have highly unequal societies. So some patients can afford specialized treatment, like if they were in the high-income countries. How should you prioritize them? I think there are 2 major indicators that we should take into consideration. One of them is the toxic mortality rate for mid-intensity regimens like CEV. For example, in Central America, it's 4%, it's around 4%, which is very high compared to Europe and the US, which is almost 0, it's probably 0. So that is something you have to be honest with your data. Why? Because CEV is the regimen that is recommended for eye preservation chemotherapy. Eye preservation. So that means that the life of the children is not in danger. So if you have a toxicity rate of 10%, you should go to a less intensive treatment, or you should enucleate more eyes, because you cannot afford to lose one in every 10 children you treat for conservative treatment. So that is a local indicator that you need to know with honesty. And the abandonment rate is also important in solid tumors. If you don't have it in retinoblastoma, your retinoblastoma may be higher. It is around 10% in Central America, where I collaborate with St. Jude. I recommend you to leave out the dogma. Sometimes what you learned when you were trained in the US and Europe is not applicable in your setting. You have to establish your priority. Saving lives come first, then saving the eyes, and then very late, the theoretical discussions that we afford to take in Europe and in the US, such as prevention of trilateral disease, pathologies, or cured by chemotherapy, etc. You won't have time for dealing to these questions. Be prepared to create your own evidence, because you cannot learn from the data in the US and Europe, because the problems you face are different and the patients you see are different. So you have to, and that is a big example from Pakistan, because you have a lot of publications. Whenever I review papers from your country, I'm very happy to see them, because you are very active, and then I congratulate you by that. But give yourself and your team permission to innovate and adapting the evidence. You shouldn't translate exactly what you see in Europe and North America. So I come back to enucleation. No, I still insist it's a life-saving procedure. It's an adequate treatment for most unilateral cases. We don't have to use intraarterial chemotherapy for these patients. We need to enucleate them upfront because it's a life-saving procedure. Be sure you do your best in enucleation. The best ophthalmologist has to do it. Take it seriously, involve yourself and your psychosocial team, because patients are not prepared for this. So they need to have time, and perhaps you have to be mindful of the cultural issues, that you need to patients accept the treatment and adapt to your resources. Why be flexible? Because sometimes you would need some chemotherapy to buy time. Families cannot decide in 1 week, and you need that. So it is always said that chemotherapy may obscure the pathology, you shouldn't use it. I agree, and I do that in my practice. But when you are there in your shoes, and then you have to decide if the family is probably coming home and never come back again, but if you give chemotherapy, these patients may have a chance of enucleation later on. These are the results published in Central America. You see there that yes, it is true, patients that receive preoperative chemotherapy don't do as well, but you save their lives. That helped to decrease the number of patients with tumor at the resection margin, to decrease abandonment to 4% from 16%. These children were saved because of this decision. 16% of them would have died. Now it is 4% by giving preoperative chemotherapy, and then wait and give time for the family for the decision. What happens if you don't have intraarterial chemotherapy? Please enucleate all patients, group D or E, with unilateral retinoblastoma, even if you have intraarterial chemotherapy. We still do that in South America. You can still use systemic chemoreduction and intravitreal chemotherapy, but don't forget that to save lives, enucleation is still needed timely, because otherwise you will have secondary dissemination and also deaths. And if you have intraarterial chemotherapy but of limited access, you have to use it for, my opinion is that you have to use it for relapse bilateral, just to avoid external beam radiation therapy. And lastly, how you treat extraocular disease with limited resources, because these children can be cured, but sometimes, again, they need a treatment that is not available in your setting. So, but if children have CNS disease, they are not cured anywhere in the world, unfortunately. You have to treat palliatively these children with a life prolongation intent. Orbital retinoblastoma is curable, especially when there is no massive optic nerve invasion. and some patients with metastasis may be still curable. So come, please, work globally, come to St. Jude. We have this excellent resource for working globally. We are welcoming you to come. And these are my conclusions, that regimen adaptations are mandatory for success in the treatment of retinoblastoma. Measure your results, then act accordingly, and then measure again. That is a cycle. Improving your results is possible when you work with these procedures. By generating local data would save children worldwide in other parts of the world. And let me finish by inviting you next Friday to this conference we have in this series of webinars we have in Barcelona. And thank you very much again for your attention.
Thank you very much, Dr. Chantada, for a very comprehensive talk and elaborating the challenges and some of the strategies which we can take. I think we'll now move on to our next talk and we'll take the questions at the end collectively here. Our next talk is by Dr. Saima Amin. She's a consultant ophthalmologist and she is head of the pediatric ophthalmology department at the LRBT hospital in Karachi. She has done FCPS in ophthalmology and she has done fellowship in pediatric ocular ophthalmology. Now, Dr. Saima Amin is going to give us a talk on recent advances in focal therapies in the management of retinoblastoma.
Hello, can everyone hear me? Yes, assalamu alaikum. Hi, everyone. I hope everyone's doing well. Thank you, Dr. Chanada, for that wonderful talk. I think we can all relate to every slide here, of course. And I must agree that most of the cases that we are salvaging are only eyes, and the percentage of eyes, the percentage of unilateral eyes that we are salvaging is very limited. So I must agree on that. So my talk is regarding the management of intraocular retinoblastoma and how it has recently evolved. So let me begin. Okay, so let me begin by elaborating on the classification systems. Now, there is a little bit of confusion regarding the classification systems because there are various versions available. So just summarizing it, the Rees-Elsper classification was introduced to assess the response of external beam radiation and to assess the likelihood of globe salvage in response to radiation. However, in the era of intravenous chemotherapy, a new classification system was formed by Murphy in 2005. And this was in accordance to the natural progression of disease and the response of conventional chemotherapy and focal therapy, the likelihood of enucleation, and that's what it assessed. So soon afterwards, Shields proposed another classification in 2006, which is quite similar to Murphy classification, but there are minor differences, and we'll address that later. And most recently, the TNM staging has been updated to include clinical categories and heritability trait. So moving on, just to give you an overview about what the grouping system is about, Group A are small lesions. We all know it's away from the visually crucial areas like the optic disc and the fovea. Group B tumors are larger tumors, but they can be of any size as long as there's no vitreous or subretinal seeding. So as long as it's a discrete tumor or multiple discrete tumors, as long as it's not occupying the vitreous or subretinal area, it's a Group B tumor. Now, when this tumor starts to give off seeds. If it's focal, it's Group C, and as soon as it starts to disseminate, it becomes Group D. So Group D has a whole spectrum from disseminated subretinal tumors, disseminated vitreous seeds, or exudative retinal detachment, more than one quadrant. And Group E eyes, again, also has another spectrum in which we include all media opacities, anterior segment involvement, and ophthalmic eyes that are basically structurally or functionally damaged. And it's almost impossible to salvage them. So moving on to the discrepancy in the system, I would just like to highlight a few major points here. We have a little bit of difference between the cutoff value of the subretinal fluid that's allowed in Group B, but the major difference lies in the Group D classification. Now, like I said, that Group B involves all tumors which do not have subretinal vitreous. They can be of any size and location. But according to the Shields criteria, if that tumor is occupying more than 50% of the globe, it enters the Group E criteria. And we know that the outcome of Group B and Group E, there's a drastic difference. So this eye here would probably be Group B according to Murphy classification, but it can be Group E according to Shields criteria. That's why there's a little bit of discrepancy in the literature. And when we see about like 33 to 40% of the eyes being salvaged, they're probably talking about the lesser advanced eyes. So moving on to tumor imaging, fundus, this is a RedCam, and it captures wide field fundus photography. It is very useful tool in assessing the progression or direction of the disease. And most importantly, what I like best about it is you can actually share the pictures with the family and they know exactly what's going on and they are on the same page as you. Another very sophisticated imaging modality is the handheld spectral domain OCT. Now here you can see that this is a small lesion which is right at the fovea, and we treated it with focal therapy and conventional chemotherapy, and this has regressed. But sometimes there are certain kinds of tumors in which you can't be completely confident if it's inactive or not. And any unnecessary focal laser is going to, of course, cause loss of central vision. So here you can see this is the cross-section of the retina, and you can see that the tumor has disappeared, and this is just an atrophic scar. So this is a very promising imaging modality, and it's very easy to monitor the disease. So this is another very useful use of this handheld spectral domain OCT. It picks up the earliest budding of tumor. So this child here was born, was delivered at 37 weeks of gestation because father had germline disease, and apparently no clinical disease, no clinical tumor was identifiable. And when we perform the OCT, you can actually see a tumor budding right off the retina. So what can be better to pick up disease before it's clinically evident? I think it's just amazing. So moving on to focal therapy, when we're talking about focal therapy in intraocular disease, we have two options. Either we freeze the tumor or we burn the tumor. So cryotherapy utilizes liquid nitrogen, which freezes the tumor to up to minus 196 degrees Celsius. And for focal therapy, when we're talking about laser, we have two kinds of laser, the green laser and the diode laser. The smaller the wavelength, the lesser the penetration. So diode lasers are usually used for thicker, bigger tumors, and the 532 green laser is used generally for smaller tumors. So this is, I just want to demonstrate how cryo works. Just one second. So this is an anteriorly located tumor, like you can see here. And what we are going to do first is we are going to locate this tumor externally on top of the sclera, and we're going to try to indent it with the cryo probe. Wait, let me just turn off the sound. Okay. So we indent it with the cryo probe. We're just trying to locate the tumor. And usually this procedure is done with the indirect ophthalmoscopy, but for the purpose of this video, I made it through the RedCam, so it's going to be a little hazy. So you see here, we have indented this tumor right here, and you will actually be able to see the ice ball being formed, and it's going to take up this entire tumor. And cryo is actually very effective. It is much more effective than laser, but of course it's accessible only for anterior located tumors. And just after one session, you can actually see that there's a chorioretinal scar, and we're able to control the tumor. So this is a case of a small group A lesion which just required focal therapy, and we performed a laser with 532 green laser, and we were able to get an atrophic scar. This is another child who presented with leukocoria, and we found a large macular tumor. This corresponds to group B, and it was very endophytic, so we proceeded and we gave chemotherapy. This is after 4 cycles of chemotherapy. You can see that the lesion is still pretty thick, and we need to focally control it now. So because the maximum benefit we get is 4 cycles when we're talking about first line, and generally tumors do not regress any further, even up to 6 cycles. So we were, after 4 sessions of laser, we were able to inactivate the entire tumor. So you can actually see parts of the inactive tumor. This is calcific, this is entirely calcific, and this is a gliotic scar. So they're both forms of inactivity. So you see here the child still has leukocoria, and sometimes parents get worried that, my child's eye is still shining, but you just have to just comfort them that the lesion is inactive, and just to come for follow-ups. Okay, so here what I want to show is this child was referred to me with this lesion here, and the clinician who was treating this child claimed that despite surrounding this lesion of so many rows of laser, they were still unable to inactivate this lesion. So there's a common misconception that if you keep surrounding the tumor with laser, it's going to cut off the retinal blood supply to the tumor and it's going to choke this tumor of blood and nutrition. But this is a misconception because this tumor is actually getting fed from the choroidal vessel, which is much, much more nutritious than the retinal vessels. So what you need to do is you need to just treat this tumor with focal laser. And the trick is to use less power, longer duration, because if you use higher power, it may disseminate the tumor and tumor may get implanted elsewhere. So the trick is low power, longer duration, and you keep cooking the tumor, give it several sessions, and thankfully we were able to get an atrophic scar. So this is another case of a group B lesion. You see this endophytic mass here. And after 4 cycles of chemotherapy and focal therapy, we were able to control this tumor. Now, what I want to draw your attention to is that this is a cavitatory lesion. Cavitatory lesions can be very tricky. It's said that cavitatory lesions are inactive, but because they have a vesicle, they may have active vitreous seeds trapped in them. So this child was to be kept on very close follow-up, and unfortunately, due to COVID, he was lost to follow-up and appeared 6 months later with a relapse. And we tried to control this with focal therapy, but we couldn't. The lesion kept enlarging. And like I said, if it's a very thick tumor, and if you do a lot of laser on very active and angry-looking tumors, you can disseminate the tumor. So we needed more chemo control, and our oncologist gave 2 more cycles of chemo, and you can actually see the tumor regressing. And in the end, guess what? We again have a cavitatory lesion, and we have to keep following this child. So when a lesion becomes inactive, it can be an atrophic scar. It can be calcific, it can be a gliotic mass, it can be an amorphous solid body as well. Now, this is an only eye of a child, a fellow eye enucleated, and it kind of is group B according to Murphy classification, and that's the one we're using and incorporated in our national guideline. So this is a really large tumor, which is occupying most of the retina, and we gave chemotherapy, and after 4 cycles of conventional first-line chemotherapy, we were able to get 3/4 of it is calcified, but the rest of it is still very angry looking, and it's still very active. The good part was this was accessible for cryo, and the lesion was not as angry as before. So we kept giving focal therapy, and thankfully we were able to completely inactivate this entire tumor and get this large calcific mass. But of course, these kind of tumors are very tricky because underlying them, they can, even if there are a few active cells, they can reactivate and cause recurrence. So these kind of children have to be on very, very close follow-ups. So yes, I must say that in the era of chemotherapy, it has revolutionized the management of retinoblastoma in terms of tumor control, in terms of metastasis, and especially in cases of germline tumor, it prevents pineloblastoma and long-term secondary malignant neoplasms. But always, it's not this perfect. There are lots of limitations. Now, for example, this case here, this eye is full of vitreous seeds, and we see active tumors underneath, but of course, it's inaccessible to focal therapy, and we've already given 4 cycles or 5 cycles of chemotherapy to this child, and unless and until you control these vitreous seeds, it's impossible to control this disease, because this active tumor is going to keep giving off these vitreous seeds, and the disease will not be able to get controlled. Let's take another example. There's an exudative retinal detachment. You see an underlying tumor, and it's still very active, and focal therapy will not really work well because there's so many retinal folds. It will be difficult for laser to actually reach the tumor, and you will not be able to completely achieve an inactive tumor. Now, again, this is another case of a disseminated disease. Only eye of a child, you see disseminated vitreous seeds and subretinal seeds, and you name it, and it's there. So it's disseminated. We gave intravenous chemotherapy. It did not work. And another example is when there are certain kind of tumor which are completely chemo-resistant, like this one here. So this is how the child presented after 6 cycles of chemotherapy. The lesion is still very angry looking and very active. Now, in all these cases, of course, we'd have to go for more toxic or second-line chemo, or, of course, because what we want to do is we want to achieve higher concentration of chemotherapy reaching the eye. So there comes the concept of targeted chemotherapy. And intraarterial chemotherapy, like Dr. Chindana mentioned, has very promising results. It has very high rates of tumor control. And for vitreous seeds also, various routes have been tried, like intravitreal, subconjunctival, and periocular. But intravitreal chemotherapy has shown the best results. So the two most common drugs that are used for vitreous seed is melphalan and topotecan. Melphalan is, I think, more effective than topotecan, but in dark iris and darkly pigmented eyes, topotecan is the preferred choice because melphalan is, the absorption of melphalan is higher in darkly pigmented eyes, and the side effects, the ERG changes and the side effects related to vision are more. So how did this intravitreal melphalan become so famous? It was tried decades and decades ago, but Francis Munier, he in 2012 developed a technique which was safe, because we know that when we insert a poke needle in a retinoblastoma eye, the retinoblastoma tumor is harvested at its highest mitotic index. It proliferates very rapidly, and any track that you leave, of course, it's going to follow that track. So if you poke a needle in an eye which is a retinoblastoma eye and you come out, obviously there are chances that you can cause orbital seeding, which is one of the would be very devastating for an eye which only has intraocular tumor. So this is a technique in which he created an anti-reflux mechanism, and he proposed the idea of needle track sterilization. And I will just show you how this works. So before that, what I want to highlight here is that intravitreal chemotherapy, it is for the first and foremost prerequisite is that the area that you're injecting should be devoid of vitreous seeds. So if there's an eye in which all four quadrants have vitreous seeds, this is not the option. Because of course, when you come out, like I said, you can give way to those vitreous seeds and it's extremely dangerous. So that's the first and foremost. The second thing is if the eye has exudative retinal detachment, your needle tip might puncture the retina and cause a regma, which might just make things worse. So these are two things that you have to be really careful about. So here we have marked the site, injected, and what we're going to do is that before we withdraw the needle, we're going to apply cryo, freeze the area, and then we're going to withdraw the needle. Again, it's important to jiggle the globe as much as possible to disperse the drug, and then you triple freeze thaw it. You do it at least 3 times to make sure that if there's any cell that may have escaped that track is deactivated by the cryo. So these are some of our results with intravitreal chemotherapy. This child, like I showed earlier, presented and was already given chemotherapy. There were active seeds and active tumor cells. And this is after 2 injections. You see that the vitreous seeds have begun to regress, and it has completely regressed now. We were able to focally treat the tumor as well, and we have ended it in a completely inactive disease. This is another case in which the child presented with this active lesion and extensive amount of vitreous seeds. The child had already received 6 cycles of CV, and the reason why we were interested to salvage this eye because this is unilateral group D. But you see the macula is spared, and the child had very good vision and very good visual potential. So that's why it was important to salvage the eye. So what we did was, luckily now you can see that the lesion is very anterior located, and I told you that cryo works much better and more efficiently than a laser would. So luckily this was accessible for cryotherapy. We repeatedly performed cryo, and also we gave intravitreal injections, and we were able to control the tumor with a good outcome. Now, what I want to also highlight here is that you see these vitreous seeds. These vitreous seeds, because of gravity, they tend to fall down and settle inferiorly, like you can see over here. Now, the riskiest thing is that sometimes wherever they settle, they may cause plantation. So it's important that if they are collecting anywhere inferiorly or anywhere, it's important to cryo that area so that you can actually take care of the focal seeds that are accumulating there so as not to prevent these seeds from planting anywhere else. So now we're going to talk about intraarterial chemotherapy. Intraarterial chemotherapy is generally indicated for non-germline retinoblastoma if it's unilateral disease. And it has got good control as far as tumor control is concerned, not so much so for vitreous seeds. Also, it is an excellent treatment modality for recurrent retinoblastoma and recurrent subretinal seeds as well. And this is just a diagrammatic representation. It's access through the femoral artery. A catheter is advanced, and the internal carotid artery is cannulated. And then it's advanced, and this is the ophthalmic artery, which is the branch of the internal carotid artery. Now, the tricky thing here is if you see here, branching off through the internal carotid artery, it's quite steep. It's like a 90-degree turn. So this is why a lot of catheterizations are failed. I mean, literature reports almost 12.5%, but of course, it depends on the expertise of the interventional radiologist. But these are some of the problems. And also, the caliber of the ophthalmic artery is much smaller, and a lot of times it goes into a spasm. So in that situation, sometimes the procedure has to be aborted, and another option is either alternatively to cannulate the external carotid artery and go through the middle meningeal. So this is the result of intraarterial, and the plus aspects which kind of differentiated from intravenous chemotherapy is that faster tumor control, definitely, because in the conventional first line chemo, you have to apply focal therapy. It's very dependent on focal therapy as well, and the tumor control rate is variable. So lesser time for tumor control. It bypasses the systemic circulation, and the most beneficial thing is you can use melphalan. Melphalan, retinoblastoma is very sensitive to melphalan, and giving very high doses concentrated right into the ophthalmic artery and right into the tumor is probably the best thing you can do. So yes, as promising as it sounds, it's been quickly adopted by a lot of centers world over, but the results are very variable. I mean, some report to have achieved 100% even in advanced cases, and some report lesser and higher number of side effects, adverse effects. So this is a literature review, and it's based on 28 publications, almost 800 eyes. And they do conclude that it has got high rates of globe salvage, but it has also reported lots of side effects. So the most reported side effect is vascular ischemia, and this is a vision-threatening side effect. It's been reported in 45 cases, and probably there are a lot of other cases which are not even reported. So if you are dealing with an only eye, of course, it depends on how confident you are with your radiologist and the results of your center. I want to draw your attention to this other issue of metastasis. Almost 20 cases of metastasis have been reported with intraarterial. So the beneficial effect of the first-line chemo, which is systemic chemo, which prevents micrometastasis, it can't be outweighed. So if you compare intraarterial chemotherapy to the conventional chemotherapy, and if you just compare the results of intraarterial chemotherapy are better in advanced cases, and they are better for recurrent cases, relapse cases, and for cases which have extensive subretinal seeding. With the advent of intravitreal chemotherapy, even with conventional chemotherapy, we are able to salvage a lot of eyes. But as far as subretinal seeding goes, the benefits of IAC are much, much higher. So now I'm going to just conclude my talk by saying that, like Dr. Chunata said, we're faced in this era of targeted chemotherapy and focal chemotherapy. We have a lot to achieve, from dealing and battling with issues of overt cases like this to picking up subclinical disease. We as a developing nation have a long, long journey ahead. Thank you everyone for your time. And
thank you very much, Dr. Saima, for a very informative talk. Now we move on to our next talk, and this is the last talk of this session. And Dr. Salman Kirmani is going to give us a talk on retinoblastoma genetics from research to implementation. Dr. Salman is a consultant pediatrician with special interest in pediatric endocrinology and medical genetics. He currently works as an associate professor and chairperson of the Division of Pediatrics and Child Health at Aga Khan University Hospital. So over to Dr. Salman for his talk.
Thank you very much. And thanks so much to Dr. Najma and the rest of the colleagues at Shaukat Khanam for inviting me to do this talk. Wonderful talks that, I have to hopefully match and keep you interested in. So this is, I'm a geneticist, and the genetics of retinoblastoma, just in terms of teaching is really a world in its own. And it really has become sort of the prototype genetic syndrome for cancer predisposition. And I'm going to use that as an example and try to really figure out how do we in Pakistan and the rest of the developing world go from research that informs the best practice to actually implementing it. And it's a tough journey. And to do that, I think Guillermo pointed out very rightly that we work a lot and awareness. You first have to start within your own community, which is your community of physicians and nurses and other health providers, and get them to appreciate the importance of a particular issue. So I'm going to try to do that by really helping everyone appreciate the importance of genetics in the care of retinoblastoma. And hopefully, once we have that core group of people who take care of patients with retinoblastoma, realize the importance of genetics, we'll then figure out a solution of how to implement this in our setting, because there are a number of challenges. So if you just give me a chance to advance my slides. I have no disclosures. The outline really will be, we'll talk a little bit about the molecular mechanisms of hereditary cancer syndromes. I'll talk about clinical decision-making in hereditary retinoblastoma, and move over to genetic counseling, and then finally the implementation challenges. So again, this is very, very basic, and really most of you in the audience know this, but what I'm trying to do for everyone is to really differentiate, what germline mutations are, which are basically mutations that one is born with, versus what happens in every cancer cell, which is somatic mutations. And so there is a difference. And if we appreciate the difference, we will understand the genetics of retinoblastoma very well. So for most cancers, the vast majority are sporadic. That is true for retinoblastoma as well. And then a percentage, about 5 to 10% in general, are considered hereditary. But then there is this green area of 15 to 20% that cluster in families where a genetic change is not appreciated by current technology. It could mean that there is not just one single gene, but multiple different changes in the genes that are causing this. Or it may mean that there are, some subtle environmental changes and gene environment interactions that lead to this. It's also important to understand that most cancer susceptibility, syndromes are inherited in an autosomal dominant fashion, but with incomplete penetrance. So it can be inherited from a parent, for example, but the parent may not display any symptoms. And that's important to understand. It's not always a de novo situation if there is no family history. And as you can see in this diagram, there are people who have, the susceptibility to the tumor, and there are people who have sporadic cancers in the family as well. And the pedigree can be hard to interpret when you have this type of combination. So really a very careful look at the pedigree, and then looking to see who has the symptoms, who doesn't, and then doing some type of testing to prove what the mechanism is, really allows you to then take care of the family. Here are some examples of other dominantly inherited cancer syndromes. And again, familial retinoblastoma is just one of them. I just put this up because there are many, many others, and this is an old slide. There will be many more. And, really the principle of tumor suppressor genes and oncogenes, everyone knows this. And, the RB1 gene is your classic tumor suppressor gene. And that's really what's at play in the tumor progression. And as you can see in the multiple, cellular pathways, if you've got a problem with the tumor suppressor gene, then you're not going to suppress cell growth at a certain point in time, and you'll have overgrowth, which will lead to the problems. And really coming to that very classic two-hit hypothesis that everyone knows about, that, you know, the first hit may happen at a very early point in development, maybe even at conception, if it's inherited. And the second hit happens somewhere along the line, you know, and we'll talk about that, because this is really where we begin to understand the genetics of retinoblastoma. So I'm going to start here at the bottom right corner of the slide. So basically, for a retinoblastoma to develop within the tumor, you need two abnormal alleles. And how do you get to this point? There are three pathways to this point. One pathway is that you are born with a germline mutation. So you are born with an abnormal allele, the other one is normal. And at, you know, sometime after birth, you develop a second hit, and so you develop the tumor. And the second hit obviously happens in the tumor tissue. On the other hand, the first hit can actually happen in embryonic life. You will begin life with two normal alleles, and really in embryonic life, a spontaneous mutation occurs. And then that second hit, just like the first example, happens sometimes after birth. The end result is the same, two abnormal alleles in the retinal tissue, which will lead to the development of retinoblastoma. And then the third one, which is rare but does happen, is that both you know, hits happen after birth. And so, you know, the first and the second hit happen after birth, probably not both at the same time, and leads to the development of, you know, again, the tumor. If we look at the presentation of retinoblastoma, you know, the majority of patients will present with unilateral tumors, and the presentation is roughly at around 24 months. The bilateral tumor patients, you know, are about 40% of the pie, and present much earlier, about 15 months. And then the trilateral patients, the ones with the pineal gland tumors, along with bilateral retinoblastoma, are very rare and also tend to present early. And then if we look at family history, you notice that only about 10% of patients with either unilateral or bilateral retinoblastoma will actually present with a positive family history. The vast majority, 90%, will have a negative family history, of which about 30% bilateral patients have a negative family history. So even bilateral patients who technically should have a 100% rate of having a mutation will have a negative family history 70% of the time. And the unilateral patients have a negative family history about 60% of the time. So this is important to remember. And in terms of predicting who will have a retinoblastoma gene mutation, this is an important, you know, clinical presentation slide to remember. Right? Excuse me. Yeah. So, you know, basically, if your family history is positive and you have bilateral disease, you essentially have a 100% chance of having an RB1 mutation. If you have a family history that's positive and you have unilateral plus a multifocal tumor, even then it's 100%. In fact, a positive family history, even with a unilateral and unifocal tumor, gives you a 100% chance. So basically, if there's a positive family history, 100% of the time, you will find an RB1 mutation if you do the right type of testing. When your family history is negative, that's where it becomes challenging. 100% of the time, if the family history is negative, but it's a bilateral tumor, you should still find a mutation. The spread is quite wide in the patients who are negative and have a unilateral plus a multifocal tumor. And this could be a wide range, and there's multiple biological reasons for that, which I will go into. And if you are negative and you have a unifocal and a unilateral tumor, there is still around a 14% chance that this could still be an RB1 mutation that you were born with. So I think this percentage is an important percentage that you do not want to miss, even in your unilateral patients with a negative family history, and hence the recommendation that all patients with retinoblastoma should be offered genetic testing. Here, I just wanted to, again, highlight the fact that there is germline testing that is used, and then there is tumor tissue testing. And they're both different, and they both give you different results. Germline testing also is not, it's not just one DNA test. There are many different types of DNA tests. So you could look at sequencing, you could look at copy number gains in parts of the gene. There could be a mutational signature, which means certain types of mutations that you could specifically look at rather than sequencing the entire gene. And there could be structural variants within the gene. These are all done on DNA. Then there are actually DNA methylation arrays that typically are done on tumor tissue, but can be done in the germline as well. And then there are RNA tests that we can sometimes offer to clarify what's happening at the DNA level. But this is all in the germline, and then there is tumor tissue testing. In retinoblastoma, there is potential to use both, and I'll walk you through what is recommended in the ideal situation, and we'll have to put our heads together to figure out what we do in the low income setting. So the principles of genetic testing in retinoblastoma really are that if tumors are bilateral, unilateral familial, or unilateral and multifocal, you should begin by performing RB1 testing for the germline on peripheral blood, which is the ideal. You could also do a cheek swab if you have the opportunity, but you know, we get better quality DNA from our blood, so it becomes practically much easier to do. So that's really the recommended test for bilateral, unilateral familial, or unilateral multifocal tumors. The cost that we currently incur outsourcing it to a lab in the US called Invite Genetics is about $250. That's about 40,000 rupees. Yes, it is expensive, especially for patients who are coming from government sector hospitals. But you know, in the big scheme of things, you know, it is much cheaper than your standard genetic test. And I think we can probably drive the cost down if somehow this becomes available in our setting. And there are probably some innovative ways to bring the cost down further. The good news is that the way the lab testing works, if a family member tests positive, all other members in the family will get free testing. So really, bang for buck, even though it's expensive, in the end, it actually ends up being cost effective. If the tumors are unilateral and unifocal with a negative family history, you know, here's the practical recommendation. If you have no tumor tissue to access to, which at least in our practice, we feel that that's the majority of the patients that I get to see, then RB1 germline testing on peripheral blood is the way to go. Because that would then at least identify those 14% of patients with a negative family history with unilateral and unifocal tumors who might still have a germline mutation and may be at risk for tumors in the other eye, plus later on other tumors associated with retinoblastoma. If tumor tissue is available, the ideal situation is that you should do RB1 testing on the tumor DNA. It is a challenge in Pakistan to actually get high quality tumor tissue to extract DNA from, and then send testing out. And I think somehow we have to work together to improve that. If the test is positive in the tumor, you have to go back to the germline to confirm whether this is a somatic mutation or a germline mutation. I think that's where it becomes important to follow up on this. And if your RB1 test on the tumor tissue is negative, then you perform methylation analysis of the RB1 promoter. This is a very special situation where the sequencing test will not pick this up, but you will have to do a special test for methylation analysis in the promoter to see if this is a promoter defect that is causing the tumor progression. And if you do not find hypermethylation in the RB1 promoter, then you test for amplification in the MYC-N gene, which is really responsible, I think, for about 1.5% of all sporadic tumors. So a very rare situation, but something that testing is available for, and at least in the ideal world is recommended. Clinically speaking, other tumors that are associated with hereditary retinoblastoma are osteosarcoma, leiomyosarcomas, rhabdomyosarcomas, and melanomas. They typically tend to manifest in the second or third decade of life, but a much, much higher incidence in those exposed to external beam radiation, and hence the recommendation to be extremely, extremely careful with offering any type of external beam radiation given the radiosensitivity of these individuals. to tumor progression. The surveillance, I know everyone in the audience is probably very familiar with this, but you can see how extensive this surveillance is for patients who are proven to be RB1 mutation positive. Although there is no clear evidence that the non-ocular tumors benefit from any type of imaging such as whole body MRI, a number of centers are trying to gather evidence of whether that kind of screening actually ends up with early detection, and if indeed early detection, does it actually help outcomes? That's really the more important thing. And right now, there is no outcome data to recommend any specific screening recommendation. Here's again from the American Academy of Ophthalmology guidelines. And again, I think the audience can appreciate the extensive follow-up that is needed for people with a high risk and even an intermediate risk for retinoblastoma. And what's important to appreciate here is that the color blue means that these exams have to be done under anesthesia. And even in very modest settings, anesthesia is costly. The exams are very disruptive to the family, to the child, and if you really need them, that's when it should happen. And that's where the role of genetic testing comes in, where by spending some extra money to do the genetic test and finding out that you may not need repeated exams under anesthesia, you might actually end up doing a lot of good. So that's really the principle here. Here are agents and circumstances to avoid: radiation, tobacco, UV light, and also some evidence that obviously chemotherapy can be toxic in its own right, and you want to limit the exposure. And I think the advocacy for intra-tumor and targeted chemotherapy may be coming from this risk. Almost all of you know this, the inheritance is autosomal dominant with a 50% chance of being inherited if it is present in any of the parents. The counseling is very, very important, and really the principles are that most patients with bilateral disease with no family history will have a de novo mutation, meaning the mutation it did not come from the parents. So that is overall good news from a family history perspective. But because there is still a possibility that there may be somatic mosaicism in any of the parents or reduced penetrance, you must offer testing to asymptomatic siblings and parents whose child is found to have an RB1 mutation, because you do not want to miss that situation. 5% of RB1 germline positive mutations inherit this from unaffected parents, as I mentioned, and this is due to mosaicism and reduced penetrance, and you want to make sure that you catch this group of people. If you do catch it, you can actually offer reproductive decision-making options to the family, be it either through amniocentesis or chorionic villus sampling, and if the family so decides, they could potentially go for termination of pregnancy if it is found that the fetus has a germline RB1 mutation. This obviously is a very personal decision, and given a lot of personal and religious input into this decision making, it must be given in a very non-directive fashion to families who then will come and make their independent choice. You can also offer pre-implantation genetic diagnosis by doing IVF and then testing the embryo for an RB1 mutation and then only implanting embryos without the mutation. This choice can be given, although it is quite expensive and currently at least not available in Pakistan, because we do not have the ability to extract DNA from the embryo quite yet. We are routinely offering CVS and amniocentesis for multiple genetic disorders for reproductive decision making. For future treatments, people are really excited about gene editing. There is currently no gene editing trial that I could find anywhere on retinoblastoma. This could be something that comes up in the future, but something to stay tuned about, because there is a lot of potential for genetic modification that could be done much more efficiently than what was done in the past. Conventional gene therapy was tried, but without any success in hereditary retinoblastoma. So I'm just going to end by sharing the AKU experience over the last 4 years. I'd like to thank my colleagues in pediatric endocrinology here at AKU who've helped with this, and colleagues in ophthalmology, obviously, who take care of the patients as well. So as you can see, most patients present with with unilateral tumors in our practice. Most have a negative family history, as you can see. But this is quite unfortunate, but even though testing is offered, the actual practical follow-through with testing is only in about 11% of our patients. And there are probably multiple barriers to this. Part of it is just, maybe just the logistics of referring to genetics. It also has to do with the family at that point, just primarily focusing on the tumor itself and not on anything else. The cost is a big issue, even though the cost has gone down. And sometimes, they come to us for one visit and then get their care elsewhere. So we have not had a chance to follow up on those patients. So multiple reasons are there, but I think we all need to work collectively to improve this number to at least 50%, if not more. We've only followed through with testing of 7 patients who were, actual proband, so the first person in the family, out of which 5 out of 7 of them tested positive. 1 was unilateral, and the 4 were bilateral tumor patients. 1 unilateral retinoblastoma patient had negative testing, and 1 unilateral retinoblastoma patient had a variant of uncertain significance that when we tested one of the parents for, the parent also had it. So we think most likely this was a negative result. So with that being said, then, which is appropriate that most unilateral retinoblastomas with a negative family history would have a negative result. Our data would be consistent with that. We ended up doing family follow-up testing on 8 further individuals after these 7, and all tested negative. So again, good news for those individuals, because those siblings then did not require any further exams under anesthesia, screening, etc., and so forth. And it was a big relief for the families. So to conclude, what difference does genetic testing make? For the parent with a retinoblastoma mutation, it gives them options for prenatal testing to prevent transmission to the next generation. I've already mentioned that. For the patient with a bilateral retinoblastoma, you basically get early testing of younger siblings to detect if they are positive, and cost-effective exams under anesthesia. And for the unilateral retinoblastoma patients, it quantifies the risk in the other eye and gives you a future risk of tumors, plus the ability to screen the family. So clear, advantages there. This is an excellent example where, in this pedigree, if you look at this proband, if you didn't have genetic testing and you would just give a theoretic possibility of who all could be at risk for carrying an RB1 mutation, all the individuals in gray are at risk, and obviously their offspring are at risk. So all of these people would have to be somehow kept under surveillance, with the younger people having exams under anesthesia and so forth, a lot of activity to be done. If, on the other hand, you tested this individual and they were found to have a de novo germline mutation, the only individuals at risk become these 2 individuals who you can test and figure out if they've inherited it or not. So clearly, genetic testing is cost effective. The implementation plan is tough, but I think this is where everyone needs to get together. I feel that we need a retinoblastoma registry integrated biobank. And I think, again, Guillermo pointed to the fact that, you need to centralize care for retinoblastoma. That has its challenges, but I think that is the way to go. The physical registry and biobank may not need to be in one physical place. I think, at least in the private sector, most hospitals do have the capacity to do this. It's just a matter of getting funding and then having the infrastructure to do it. But I think integrating the biobank with the clinical registry is key to then really move forward. You need the multi-center collaboration to really make this work. And it's somehow, all of this activity has to be subsidized or grant funded, because expecting the patient and the family to pay for all of this is only going to be beneficial for a small percentage and not for the larger population. And then I know that the PSPO group has worked very hard at coming up with national guidelines. But I think what we need to do is audit those guidelines with evidence and then modify that evidence according to what we, modify those guidelines according to the evidence we find and move forward. So in summary, all patients with retinoblastoma should be offered genetic testing regardless of family history. And I really use the term offered genetic testing very carefully. I'm not saying that you test everyone. I'm just saying you offer it. It is the individual family's choice and whether they go for it or not, but at least you are offering it as part of standard of care. Lifelong follow-up with eye exams and awareness of risk of associated tumors is needed for the ones who are RB1 positive. Couples should be offered reproductive options to prevent recurrence in future offspring. And we need a concerted effort to offer genetic testing as part of routine care. So thank you very much for this opportunity to present. And thanks to my colleagues, and I'm happy to take questions. I'll stop sharing my slides now. Thank you very much.
Thank you very much, Dr. Salman, for updating us on the retinoblastoma genetics. Now I'll request the participants, they can ask the questions and they can even type it in the question and answer session while we take the rest of the questions and ask the answers from our expert speaker. Now we have a couple of questions that are being asked. There is a question by Rabia that how many cycles of intra-arterial melphalan are recommended? I'll request Dr. Saima to kindly comment on that.
Okay. It basically depends on the response of the tumor. Generally, it's advisable to give 4 cycles of intra-arterial, but it depends on the response of the tumor, basically, because every tumor responds differently. Some tumors will respond very well to even 2 cycles, and some, if they have not responded at all, even after 2 cycles, you probably would take the decision of not going any further. So it depends upon the response to treatment.
Thank you. There's another question, I think, from Dr. Saima too, and that is, how did you make sure that intraocular lesion is inactive after focal therapy?
Okay, so first and foremost, it depends. If it's a flat scar, there's no 2 things about it. If it's a flat scar, you get what you achieve. Now, for thicker tumors, for more advanced tumors that I showed in my video, sometimes you can never be sure. You have to keep following, and if after let's say maybe 2 to 3 months, if the lesion is showing no activity at all, no progression, that means that lesion was inactive. So sometimes for thicker tumors, you just have to go with the flow. You just have to keep observing and closely follow the tumor, and that's what we have red cam images. So we, the suspicious areas, we particularly focus them and we take multiple images and then we compare. So if it is an inactive tumor after 2 to 3 EUAs, you're going to see that the tumor is involuting. So sometimes you can't tell 100%, especially if you don't have an OCT and you're not monitoring through that, you can't tell 100%. But yes, for smaller tumors, if it's completely calcified or if it's a gliotic scar or a flat scar, then it's inactive.
Thank you, Dr. Saima. There were a couple of questions which I think Dr. Chantada has already answered, but for everybody's convenience, I think I will request Dr. Chantada to elaborate it a bit further. And the first was, what is the role of chemotherapeutic agents other than melphalan in intraarterial chemotherapy? Dr. Chantada, would you like to highlight it further?
Yes, of course. And yes, I think it is important to know that when you have to treat bilateral disease, you cannot rely only on melphalan, because if you give only melphalan to both eyes, you should reduce the dose, the total dose of melphalan, because otherwise it should be very toxic to the hematopoietic system. So in those cases, when you're treating both eyes at the same time, it is mandatory to add other drugs like carboplatin and topotecan. When you're treating a single eye, it is quite controversial. We as pediatric oncology don't like too much to use a single drug, and we always use in other tumors multiple chemotherapy to overcome probable resistance. So at least in our practice in Barcelona and in South America, we always add topotecan to the regimen of melphalan. It's very, very uncommon that we would use only melphalan, but this has not been proven by a randomized study.
Okay, thank you. And there was another question that what could be the treatment for trilateral retinoblastoma in lower middle income countries? Would you like to highlight on that too?
Yeah, absolutely. Yeah, well, trilateral retinoblastoma is very difficult to treat, and the results are very discouraging worldwide, probably not reaching 10 to 20%, even with high-dose chemotherapy and stem cell rescue. So even in limited resources, I think these children should be offered curative treatment with higher dose chemotherapy you could give for a CNS tumor. You have to treat these children with a CNS tumor specialist. And depending on the, well, we use also intrathecal topotecan for these children, which is very low toxic and potentially active, because maybe usually these are young children that they cannot receive radiotherapy. But if they are older ones and the dissemination is leptomeningeal, or if you're giving like a palliative treatment, radiation therapy can play a role. Very seldom the tumors are resectable. And if so, it's better to try and resect like you manage a pinealoblastoma tumor in non-retinoblastoma patient. But usually it is not possible either to resect or either to irradiate these children, and you should rely on chemotherapy.
All right, thank you very much. I'll request the participants, if they have any more questions, they can ask right now. We have the experts with us. And meanwhile, Dr. Salman, I would like to know, are we offering prenatal genetic diagnosis for retinoblastoma in Pakistan, and how is the family's response to that?
Yes,
Are
thank
they
you so
going
much.
for?
Right. So the answer is yes, we are offering it. We have not had a single, as I mentioned, a parent with it so far. So you would only, offer it if the parent had an RB1 mutation and they had a chance of having another child with it. So practically speaking, we have not been able to offer it to any specific family. But in general, yes, we do have the ability to do CVS and amniocentesis. The classic disorder for which this is offered all over Pakistan is beta thalassemia. So the principle is the same. If you can do it for thalassemia, you can do it for retinoblastoma or any other single gene disorder.
My next question would be, yeah, there's another question right now here. We'll take that first. What other genetic testing for pediatric oncology cases are available in Pakistan? I think Dr. Salman, it's from you.
Okay. Well, I think so. So to tell you the truth, there is very limited testing in Pakistan. So we send it abroad. I'm sending it to Invite Genetics in San Francisco. They're a very easy lab to work with, very high quality results. The interpretation is fantastic. And, you can go back and forth with them and they can share the data with you as well if you need to. We send the samples through DHL. And they are actually one of the most cost-effective labs anywhere in the world. Europe, in general, is much more expensive. Even in the US, they are one of the least expensive labs. They are a very high throughput lab, and that's why they can offer this type of price. We were trying to establish next generation sequencing tests over here in Pakistan at AKU. But because all of the reagents, all of the machines, all of the raw material actually comes from abroad, the actual cost of the test becomes huge. So unless you have a huge volume, you're not going to be able to bring the cost down. So the short answer is you can pretty much test for anything in Pakistan as long as you're willing to send the samples abroad. And it's easy to do that. It's not difficult. So all, tumor predisposition syndromes can be covered. And the good news is that with panel-based testing, in one sample, you can test for multiple different disorders that could be on your differential. The problem lies in the interpretation, because the more genes you test, the more variants of uncertain significance you get. And we are getting a lot of those, and those can be hard to interpret, but that's part and parcel of genetic testing. And as long as we are willing to test our people and then getting normative data, we will solve this problem.
So thank you very much. Thank you very much, Dr. Jantada. Thank you, Dr. Saima and Dr. Salman Kirmani for excellent talks. And thank you to the participants for their active participation. So now our next session will start exactly at 3:40. So there is a short time break for all of you. Thank you very much, all of you.